So Dr. Lisa Wickerson is a physiotherapist and clinician investigator within the Toronto Lung Transplant Program at the University Health Network. Following completion of her PhD in rehab science, Lisa undertook a postdoctoral fellow at Women's College Hospital Institute for Health System Solutions and Virtual Care at the University and the University Health Network's Transplant Program. Her research focused on remote rehabilitation monitoring to support integrated care and optimize functional outcomes before and after transplantation, which turned out to be a very timely topic. So we're very pleased to have Dr. Wickerson as an invited speaker at our symposium to present rapid adoption of tele-rehabilitation, the experience of a large lung transplant center.
Great. Thank you, Sunita. Can everyone hear me okay and see my slides?
We can see your slides.
Okay, great.
No, we cannot.
Yeah,
you
so
can.
you want to try your screen share again, but we can hear you okay.
All right. Okay. Okay. Okay, can you see it now?
No. Are you running multiple monitors, Lisa?
Nope, just one.
Okay, so let's go down to the green box again.
Okay.
When you click on that, does it bring up all of your open windows?
Yes.
Okay, so click on your PowerPoint presentation specifically.
Okay, I'm gonna actually just go to my,
There we go.
I'm gonna go this way. I'm gonna go this way.
Sure.
There we go. How is that?
Yeah, just perfect. Just go to your full screen mode. There we go. Awesome.
Okay, great. Okay, so thank you very much, Sunita, for the introduction, and I have no conflicts of interest to declare. So the objectives of this presentation is, as Sunita said, I'm going to describe the rapid adoption of tele-rehabilitation in lung transplant candidates and recipients during the COVID pandemic. And I'm going to share some early program evaluation results and discuss considerations for a hybrid rehabilitation model. So I work at a very large lung transplant center. We do over 200 transplants a year. And we have a mandatory center-based rehabilitation program. So typically pre-transplant, people exercise at our center for a month, 3 times a week. And then after that, we'll either continue at our center 3 times a week or do a combination at our center and at local rehab programs. They're all center-based and supervised. And then after transplant, they are supervised once they're discharged from hospital until 3 months post-transplant. So traditionally, we have not had a tele-rehab or a home program capability in our program. So last year, as we were preparing to investigate a remote rehab program, we asked patients their perspectives on the supervised model that we have. And people did like the program in that it prepared them for surgery. It ensured that they did the exercise. They liked the monitoring and the progression of exercise and the expertise of the staff. And more importantly, they enjoyed meeting patients and support people and having that sense of community. What they didn't like so much is that there was no remote option and that there was time associated with travel. Our patients with cystic fibrosis had to come at very specific time points. They weren't as flexible with their sessions. And there was a need, they wanted more space, more equipment, more time to do the program. Again, we would have over 30 patients a day exercising, so often it was hard to finish everything in the time. And it was very time intensive for patients and their caregivers. And there's different models of telepulmonary rehabilitation. There's certainly the synchronous model where patients can be supervised by video conferencing and have their vitals monitored. So therapists can do this with one-on-one with a patient or may have several patients together in a group session. But we were interested in the asynchronous model. So using a mobile phone or a web or app-based where health data is captured and then transmitted and later interpreted by the healthcare professional. So this last 3 months, which it's hard for me to believe it's only been 3 months, it feels a lot longer, but with COVID, there's really been an evolution of kind of circumstances and issues that we've been dealing with. Initially, we had this large-scale implementation when everything closed down mid-March with people that were currently exercising. Then the last couple months, we've had to deal with issues with new patients being listed in the remote setting, so not seeing them on site, continuing to do transplant functional assessments, and then dealing with disease progression as people are waiting on the list longer for transplant. And then where we are currently trying to figure out where we fit in with our program, with the phased clinical activity restart, and how to plan for the new normal. And when we look at tele-rehabilitation, it's important to note the differences between pre-COVID and during COVID. Traditionally, pulmonary rehab remote models, they would have an intake assessment, initial training in person before going to the home model. And during COVID, we've had to do this completely from a remote setting. The rationale for remote rehab pre-COVID is issues around access, so people being in remote areas, center-based programs not being available, adherence, trying to encourage adherence and sustainability, whereas during COVID, it was all around infection control and having to close programs down and how to offer it remotely. And obviously the environment is very different. So pre-COVID, there's access to local community centers, gyms in people's condos. It was safe to walk outside. You were able to purchase exercise equipment and monitoring equipment in a timely manner. And as we know, during COVID, that hasn't been the case. So some important differences during this time. So at our center, we actually were starting a 2-year pilot looking at a customized web-based care app. And this app that we chose was able to have personalized care plans, biometric data monitoring, patient education surveys and reminders. It had secure asynchronous texting, and it had video visit capability. And there was manual entry of biometric data. So the system that we are piloting, it didn't have automatic download of Bluetooth devices, but again, it was something that we were looking at, aiming for a hybrid model. So initially, they would be on site, we would do that functional assessment and training for that first 4 weeks, and then move them to a hybrid model. And what we were doing in the pilot is really developing and piloting it in a small group. So we had, starting in January of this year, we had 10 patients pre and post lung transplant who were trialing it out and giving us some feedback as we were trying to refine it and make it better before we implemented it more broadly to everyone. So this app was used for medical care and rehabilitation. So I was in charge of customizing and designing the rehab exercise pathway. So we included surveys such as asking them about their availability of home exercise equipment, any functional changes since the time of their transplant assessment. We had symptom and physical activity surveys, and there's app user satisfaction surveys that are incorporated into the app. We also had educational resource library. So we had text and video resources on exercise pre and post surgery. We could put in prompts of telling people what to access and when. We could track to see if they access the resources, and we could put in teach back questions around education. And because we had to move completely off-site and we had new people starting our program, we did make a video and post it of our whole exercise program so that people could follow along as a resource. We also have an exercise pathway. So this is pushed to people on either their phone or their tablet. And they track their exercise volumes and physical activity and their physiological responses. And we can track adherence, and we can also put in alerts. So if people have a Fitbit, we can put in a low step alert for the day that would highlight that to us if they were not walking very much that day. So getting back to mid-March, so the app was quickly scaled up so we had 75 people pre-transplant and in the first 3 months post-transplant that were immediately put on the app. And they had already currently been exercising with us, so we were continuing their exercise program, doing physical activity counseling and oxygen titration. And I'm going to talk a bit about challenges, but I have to say that there were some benefits that we actually had this partially developed app, and it was this benefit to be able to use something as there were a lack of other options as a way to connect and communicate with people in this very stressful and uncertain time. That said, we did encourage quite a few challenges. So in terms of the patient challenges, some people did not have any exercise equipment. They might not have had oxygen oximeters or not very high quality ones. If they didn't have a tablet or smartphone, they couldn't be on the app. And again, there might have been a lack of access or experience with technology. And with the clinical team, in the pilot, we initially were trialing the post-op period. So from discharge from hospital to 3 months post-transplant. So our pre-transplant pathway wasn't fully developed. Our clinical workflows weren't fully defined or determined. We hadn't fully developed our standard operating procedures for the app. And again, there was a lack of technology access and experience. So from April to June, because we're a transplant program, we were continually listing new people for transplant, and we were having to do transplant functional assessments as well as serial functional assessments. So there was a 6-week period where we weren't doing any lung transplants at all. And normally in that time period, we would have done about 25 transplants. So there were people that would, were waiting and sort of deteriorating in their function. And we had to decide how we could assess this and deal with this remotely. So again, challenges are around technology issues, lack of orientation to program and exercise expectation for the new patients who didn't know us and hadn't been on site. Issues around safety and efficacy of oxygen and exercise prescription and monitoring. And it is the thought from the physiotherapists in our program that probably people were generally being undertrained a little bit just because of lack of equipment and monitoring. And we're having to deal with potentially non-medical grade oximeters to make decisions. And there was this lack of information on reliable remote assessment measures. So I am very excited for Dr. Holland's talk later today to find out the results of her research on this topic. But as there wasn't much, we had to make some decisions. So we did videotape the short physical performance battery, which is one of the tests we do to look at physical frailty pre-transplant. So we did a video. We would send it to patients ahead of time to watch and to set up their home so that when we did our video visit, they would be prepared to do that. And that generally worked okay. But what we struggled with was how to assess functional exercise capacity and exertional oxygen needs that we usually do through a 6-minute walk test, and what would be a reliable and safe measure to do. So what we're dealing with today is that this slow phase clinical activity restart, and knowing that the physical distancing measures that we have to do in our rehab program is going to reduce the number of rehab spaces and availability for on-site care. And so we need to develop a new model of care. We need to think about health equity in terms of access that people have to smartphones, technology, internet, access to equipment, and then thinking ahead, hopefully not, but if there is a second wave and how we again deal with those restrictions again. So I wanted to share some early program evaluation results. So I looked on the app from mid-March to the beginning of June for people that had used the app for at least 4 weeks. So we had 80 people, 47 transplant candidates and 33 transplant recipients, and half had rehab on site before the COVID and half were new patients who had not seen us on site. So when we look at pre-transplant, the survey with equipment, you can see that most people had an oxygen oximeter, although again, very variety of quality of oximeters. Less than half had a treadmill. Most people had some sort of weights, but not necessarily a big range that they could progress with. Not many people had an activity tracker, and 44% of people were alone during the day when they exercised. So we do ask, do a survey of the rapid assessment of physical activity. So what we do is when, with people that are starting, with the app pre-transplant, we ask them to fill out the survey on the app, and then 4 weeks after, ask them to fill it out again. And so what we saw here is that after 4 weeks, there was more people reporting that they were active, which meant that they were doing at least 30 minutes of moderate physical activity 5 days a week or more. When we asked people who were post-transplant at the 3-month time point to fill out the RAPA, we did say that there was a high proportion, so 86% reported that they were active at the 3-month point, which we were happy with that. When we look at changes in training loads, this is the post-transplant group. So we didn't have a lot of people that actually had a treadmill, but in the people that did have a treadmill, between 6 weeks and 12 weeks post-transplant, there were increases in their walking speed. And in terms of looking at the amount of weight they used for their quadricep exercise, that increased as well. So that is good because we want a continual exercise progression in the post-transplant period. When we look at the patient app satisfaction survey, so pre-transplant, 75% agreed or strongly agreed that it helped. So the app and this clinical model that we were offering through the app helped preparing them for surgery, helped them learn about their health condition, and empowered them to manage their health condition. And in the post-transplant candidates, 80% agreed or strongly agreed that it supported them through their recovery period. They found the daily check-ins were helpful, the texting feature and video visits were helpful, and that it improved their confidence in taking care of themselves and empowered them. So we also did a physiotherapy survey. So there's 3 of us that worked there clinically and to see how we were managing and our perceptions about the app. So it was used as part of our daily workflow. So in terms of people that were listed on the program and were exercising, we were getting about 30 text messages that we had to respond to about exercise, and we were doing about 40 video visits a week. And we were doing a ratio of about 80% video to 20% phone visits. Again, because we weren't seeing people in person, we were doing a lot more video visits. And the times we were doing phone visits is we were having challenges with technology. But looking at a hybrid model, we would change that a bit if we were seeing them on site. There was moderate satisfaction with the app, and we really like the in-app video calls, especially when we're not seeing them on site and we're used to seeing them 3 times a week. So the video visits were very helpful for us and for patients. So when we look at the clinical benefits, so we did find a strong clinical benefit that patients could access educational resources, that they could report their biometrics, and it was a good way of communicating with patients, and that we could monitor trends in their exercise. But we did have less of a benefit around clinical assessment and really identifying a clinical change, especially in early clinical deterioration in their status. In terms of barriers, again, we really didn't feel that we had a reliable patient assessment measure of functional exercise capacity and deterioration in exertional oxygen needs. For people that didn't have access to home equipment or monitoring, that was definitely a challenge and a barrier. And in terms of being able to just prescribe and progress exercise to the same extent we would on site was a barrier. Clinical workflow, so again, it was quite time consuming both clinically and from an administrative standpoint. And certainly for new patients who had no prior on-site program and didn't know us and weren't on site, that was a barrier compared to the people that we had seen on site previously before the shutdown. And there was a lack of integration with Bluetooth devices such as oximeters and activity trackers. We didn't really feel that there was a barrier in terms of patient adherence, privacy, or exercise monitoring. So in terms of a future hybrid model, so we're looking at developing what the clinical technical model should look like. And we've had some direction from our program from both a rehab and a medical standpoint that they want to eventually go to a 50-50 remote to on-site visit model. So we need to look at what resources are required, both for clinical and administrative workflows, and who to prioritize who's on site. So some of the early thoughts that we've had from our experience for the last 3 months is that initial assessment should be prioritized to see on site for reassessments if we think that there is a clinical change, and for initial exercise prescription. So for people who are newly listed or at hospital discharge after transplant, and then certainly considering people that have a lack of access to exercise and monitoring equipment may need to come in more frequently. This is my last slide in terms of future opportunities, and I think there is a lot. One thing that we are investigating is, again, pairing with Bluetooth devices, so specifically oximetry and medical grade oximetry. So we've ordered some, we're still waiting for them to arrive, but looking at sort of trends sort of during exercise and maybe even some activities of daily living that are quite challenging, and being able to get that data and analyze it, as well as activity trackers, and then looking at different types of exercise equipment that are Bluetooth enabled on-site and also remote program, and see how we can link that with our app to get more information and provide more targeted prescription and advice. I'm going to end there because I think I'm at my time. Just gonna stop sharing. And I'm open for any questions.
Great. Thank you so much, Lisa. We have already had a couple of questions, and I'll read them out to you.
Okay.
So one was regarding just sharing some information, your YouTube links. I believe Leanne shared one of them, but after the talk, if you could, if you're willing to share your YouTube links in the chat box, you can go ahead and do that. There was also a question if the web-based remote care app is available for other sites to use, or is that just for UHN?
Yes, you can still hear me. Okay.
Yes.
Do you want to see my video, or here? I think I went off my video. Okay. Yes, so the app, so it is a commercially available app. So our program, it's an innovative project, so there is a cost associated with it. So it is, other programs have used it before. Actually, at our hospital, we have different surgical programs that are using it. So like bariatric surgery and thoracic surgery are using it. But yes, it requires that you would go into business with this vendor, and then it's customizable. So we're customizing it to our needs. And why we chose this one is because we're in Ontario, they said that there's certain vendors that we could work with in terms that would meet the security and legal and privacy issues with our hospitals. So you could use it, but it's not something that's free. But that said, any resources that we create for our program, if you then go to work with this vendor, you could have access to our resources on there. So they are shared. There were resources there, but we found they weren't specific enough to the needs that we needed. So we created some and put all our educational resources on there. So I hope that answered your question.
Great. So Kelly, if you want to follow up with Lisa, you can do that in the chat with her. And I'll ask you one more question. Did you find patients had issues with their data limits on their phones or tablets when they were trying to access?
Yeah, so we haven't heard that. Now, we have had some challenges with people that are either really up high in condos, really high, or in basement apartments in terms of, the Wi-Fi signal. And again, we've really had this advice of not going out into public. So sometimes the connectivity hasn't been great for video visits, and we've had to do more texting and some phone calls, but we haven't heard that yet. We are going to be looking into that. But generally, we were advising people to, not use their data and use Wi-Fi. But we haven't heard anything to date, but that is something that we're going to look at. The only issue we have is some people, didn't have access to the smartphones to do that. So that's something I think as we go forward, we have to look at resources and supporting that all people on the program would have access to this model of care and communication with their team. So that's something going forward that our program is looking at.
Great. Thank you so much, Lisa.